Dr. Ohye is our speaker today. He is proud to hold the Edward L. Bovee MD Professorship of Cardiac Surgery at the University of Michigan Medical School. He has the honor of serving as the Vice Chair of the Department of Cardiac Surgery, the head of the section of Pediatric Cardiovascular Surgery, and the co-director of the University of Michigan C.S. Mott Children's Hospital Congenital Heart Center. Dr. Ohye is a co-founder of the clinical research arm of the Heart Center, the Michigan Congenital Heart Outcomes Research and Discovery Program, and remains active in its leadership. He serves as a co-principal investigator of the Heart Center's U01 for the NHLBI-sponsored Pediatric Heart Network. Through the Pediatric Heart Network, Dr. Ohye was the study chair of the single ventricle reconstruction trial, the first multi-institutional randomized clinical trial performed in congenital heart surgery. He has a strong interest in the role of culture in high-functioning organizations, collaborative learning, and multi-institutional consortia to improve quality of care and innovative cardiac device development. He is husband to his wife of 25 years and Ironman ×2, Bonnie Ohye, and proud father of 2 daughters, Maddie and Lily, and 3 rescue dogs. His only regret in life is that he wishes he were a better beer league hockey player. Today, he will be giving his talk titled,
If I can figure out how to share the screen, I can put it up.
Yes, 3D printed patient-specific airway splints for tracheobronchomalacia. Thank you for joining us today, Dr. Ohye.
Thanks, Curtis. Now I got to figure out why my screen is not showing. Why I'm not having the option to show. Interesting.
You have a share screen button at the bottom?
Yeah, but it's some reason my talk isn't showing up as an option. Let me close it and reopen PowerPoint here. All right, let's see if it gives me the option now. Yes, there it is. All right, is it showing up?
Yes, it is.
Zoom says so, so it must be true. Fortunately, it doesn't show up very well on my screen. That's okay. So thanks again, Curtis, and thanks, Gaurav, for inviting me to speak today at Grand Rounds. And we'll be speaking, as Curtis said, on 3D printed patient-specific bioresorbable airway splints for pediatric tracheobronchomalacia. And I'll kind of go over each one of those. It's kind of a long title with a lot of words in it, but I'll go over each one of those as each one is important. Let's see if I can get this to go. So I have no disclosures pertinent to this discussion. I love medical history, so I thought I would come up with some sort of an appropriate story of historical medicine. And so I thought I'd talk about innovation, because innovation can be hard. Everybody on this call knows what mitral stenosis is. You know, in the earlier part of the century, or last century actually now, I guess, mitral stenosis was a real scourge because of rheumatic heart disease. It was a real problem. They didn't have any way to treat it, but really a real blot on society at that time. So this is Charles Bailey, and sorry if I look away periodically because it shows up on this screen of mine. But Charles Bailey was on the cover of Time magazine. You can see Inside the Heart: Newest Advances in Surgery, and he's there on the cover. And this was 1957, but he wasn't always so celebrated. So Dr. Bailey decided that he was going to figure out how to treat mitral stenosis surgically. So in November 1945, you have to remember, of course, this is before the time of cardiopulmonary bypass, so you couldn't stop the heart, you couldn't go inside the heart. So in 1945, what he did was he put a purse string in the left atrium. He wasn't the first person to try this. Put a purse string in the left atrium, and the idea is you put your finger or a knife and you blindly try to open the mitral valve. The purse string tore out. He describes in his op-note how he tried to put a clamp on it, but he was unsuccessful. And in his words, massive uncontrollable hemorrhage resulting in with immediate fatality. He tries again on June 2nd, or I'm sorry, in June 1946, but again, the patient succumbs. So at this point, he's now being called a butcher at his hospital. And the chief of cardiology says that he can't do this anymore. He said, and the chief of cardiology is quoted as saying, "It's my Christian duty not to permit you to perform any more of such homicidal operations." And Charles Bailey replies, "It is my Christian duty to perfect this operation. Nothing could be worse than what mitral stenosis does to people." So he's still determined. So you wait 2 more years later at a different hospital in Wilmington. He's from Philadelphia. He goes and tries this again, and operation is successful, but the patient unfortunately dies postoperatively of internal bleeding due to an inadvertent overdose of heparin and pulmonary edema. So now he's pitching an 0 for, he's 0 for 3. And so what he does is he schedules 2 cases in Philadelphia at 2 different hospitals, and he's very open about it. He frankly says, if the operations were done at different hospitals, the probability was great that the news of the mortality from the first operation would not reach the second hospital in time to interrupt the performance of the later procedure. So he's planning on doing the first operation. He expects the patient to die. He's going to jump in his car. He's going to go across town to Episcopal Hospital and do the second operation. So this is the first of those 2 patients, case number 4. So he does the sternotomy and the patient immediately arrests. And so he's doing open cardiac massage, and the patient's primary physician is attendance, which was common back then. And the physician says, please try to fix this. And Bailey says, I'm not going to do it unless you say declare this patient dead, so that he won't have sort of the operative mortality. So the primary physician says, okay, declares the patient dead. Bailey puts his finger through the purse string, forces his finger through the valve, runs around, opens up the valve, but the patient unfortunately remains dead. So gets in his car, runs across town to Episcopal Hospital in Philly, and there's a 24-year-old female who had just had a baby, and she was bedridden. And she said, I would rather be dead than have to stay in this bed and not be able to care for my newborn child. And so she was fully aware that he had not had any successes, nor had anybody had any successes with treatment of mitral stenosis. So he puts purse string in. He describes using both sharp with a hooked knife, and some people on this call will know they had all kinds of crazy things. Like one guy had taken a thimble of his wife and in his garage soldered on one of those hooked blades. I forget what number they are, but it soldered it on the end. And so, but Bailey just takes a knife, puts it through, and blindly kind of runs around with this knife, and then sticks his finger through and opens up the mitral valve. And it's a success. She survives. And on post-op day number 7, he puts this lady in his car and drives her from Philadelphia to Chicago, and presents her at the American College of Chest Physicians meeting. And she survived, had 2 more children, and lived 62 years of age. So just a little history of innovation. And sometimes innovation is tough, and sometimes you have to persevere through some tough stuff. So let's get back now to the splint, which is what I'm supposed to be talking about. Otherwise, I'd love to talk about history of medicine for a whole talk. Maybe I should have, but so a little bit about background, and everybody on this call will know what tracheobronchomalacia is, I think. But what it is, it's a lack of structural integrity of the cartilage of the airway. It allows the airway to collapse. If you're spontaneously breathing primarily on exhalation, the airway collapses. Severe forms have very high mortality in the 50 to 80% range. So I'm going to tell you about a couple of cases. I'll start off with case number 1. This is literally the first case we did. This is our index case. This patient was a 3-month-old male infant. He was a preemie initially, but spent a couple days in the NICU and then went home, was doing well. 6 weeks, he started to have some symptoms of respiratory difficulties. He wasn't feeding as well. And then one day he arrested at home. And fortunately, his father was able to resuscitate him. They lived across the street from a firehouse. So the dad resuscitated him, zipped him across the street to the firehouse. They were able to continue resuscitation and get him to the hospital. He'd still continue to do really poorly in the hospital. He was intubated. He was on a high PEEP at 15, and despite even being paralyzed and sedated, was still having multiple respiratory arrests, requiring CPR, and he was transferred to our hospital, basically in extremis. And here is, of course, the problem. He had tracheobronchomalacia, in this case, left main stem bronchus is on exhalation, completely occluded. You can see here in the middle frame, it's that left lung is obviously incredibly hyperinflated. It's exactly the opposite of what you want to see, right? The parenchyma should be white, the airway should be dark, and you can see the airways. You can probably see that there's filled with fluid bubbles. It's post-obstructive pneumonia. Here's bronchoscopy on the far right, and you can see that that's the carina with the left main stem completely blocked off, and you can even see a little bit of purulent material coming out of it. And he was an extremist. He was having continual arrests. He was septic and was frankly dying. But fortunately for him, these two smart guys, and I take no credit for designing this or thinking of it, I'm just the plumber that puts it in. So that is Scott Hollister on your left and Glenn Green on your right. So Scott is a biomedical engineer with a specialty in additive manufacturing or 3D printing. And Glenn, as many of you will know, is a pediatric otolaryngologist. And so Glenn thought, well, here's this terrible problem. We have no treatment for it. Stents don't work well for this. So what if we put it on the outside? So we had an idea of making this device. I'm not sure if you can see my cursor, but it's a horseshoe-shaped device that goes 270 degrees around the airway. And the panel B, the lower panel, that's supposed to show how with tracheomalacia, the airway collapses. And then the splint is put around and stitches are taken and suspends the airway inside the splint. The last panel in that panel B shows that it's built with sort of an opening pressure so that to allow for growth, it will expand and not impede growth. It's of course also bioresorbable. So in that sense, it will also hopefully in the long run not impede growth. We like it. We don't really know exactly how long it's going to last or how long it's going to have structural integrity. Probably somewhere in the 2 to 4 year range is what we're thinking. And that's what you need to allow that airway to stiffen back up again. If you think about traditional treatments for less severe forms would include positive pressure ventilation, trach, and positive pressure to split that airway open with air pressure. And usually we'll tell the families it takes about 2 years for the airways to stiffen up before the kids can get decannulated. It's designed using the patient's own 3D CT data set, so it is patient specific. It's put together using what's called laser sintering. It's a form of 3D printing. We use polycaprolactone or PCL. It's a well-known, well-characterized bioresorbable material that's used in a lot of things like plates for facial reconstruction. And how laser sintering works is the arm sweeps across, leaves a thin layer of powder. The laser comes and essentially melts the powder in exactly where you want it. Arm sweeps across, puts another thin layer of powder. Laser again melts it until you build up layers and layers until you finally come out with this 3D splint. Skip that. That just shows, that was a little video, but we don't really do virtual surgery. It's just a little eye candy. But this is actually from the operating room. Scott also made a 3D model of the airway, and you can see how the splint is going to go around the airway. This was right after the operation. So how it's put in, standard median sternotomy, cardiopulmonary bypass if necessary. This kid, as soon as I opened his chest, he was very unstable, so I immediately put him on bypass. In fact, talk a little bit about the first couple patients, but the first 5 were very sick, very unstable, so all were done on cardiopulmonary bypass. You dissect out the trachea and or the bronchi, depending on where you need to put the splint. And you have to get, like I said, 270 degrees around. We don't really preserve the vascular attachments. I try to preserve some of the plexus, but we've not had any problems with breakdown or ischemia. Sometimes we use bronchoscopy intraoperatively to tell exactly where the area of malacia starts and stops. And then we select the splint based on what the airway looks like. We'll have a range, usually 2 millimeters above and 2 millimeters below what we think it's going to be based on the CT scan. We put the sutures around the airway and then suspend the airway within the splint by passing the sutures through the interstices of the splint. Here's that case number 1. The panel left obviously is the operative field, head above, feet below, sort of surgeon's eye view. You can see the trachea coming down. The carina is here, and there's the airway, and you can probably make out some of the proline stitches that are holding the airway up. And here's the post-operative picture of that left mainstem bronchus, now completely patent. When we first put it in, and we've learned that this is very common, tons of pus came out. And I will say that most people on this call have been in the OR and know that it's very matter of fact, it's business like as usual. It's not like I think people that don't go to the OR, I think there's like a lot of excitement and yelling and screaming. But it's usually pretty business-like and run of the mill. But I have to say that this was the one time. So here's this kid with this huge hyperinflated lung, can't ventilate him. Put the splint in, the lung collapses down. It's kind of gross, but all this pus comes out, and they're able to ventilate. And I would say that this was probably the only time I've been in the OR where everyone's kind of quiet. It was like wow, something really cool just happened. Something really important just happened. But it was really kind of a neat moment in the operating room for me. So he comes into the operating room. He's acidotic. His PCO2 is 88. His bicarb is 42. And you can see even in the operating room, once the splint's on, he's already normalized and continues to do well over time. Here's his PEEP, comes into the OR at 14. Intraoperatively, we're able to drop him down to 7 or so. And then he's on maintenance PEEP by a week out and extubated by post-op day number 21. Here on the left side, so here's his preoperative, and you can see with expiration in the magenta and in inspiration preoperatively in cyan, you can see how it's collapsed down completely in expiration, and then widely patent 1 month post-op. Like I mentioned, we worry about airway growth. The hashed lines are the untreated bronchus, and the solid line is the treated bronchus. Preoperatively, obviously, the untreated is much smaller than the treated, and then you can see by 1 month through 30 months, there's parallel growth of both bronchi. So this caused a firestorm of media attention, this one case. And in fact, the PR told me that this got more hits than the national championship in 1997 of the football team. You can see USA Today, something Asian there, Nature, CNN, 10 things that were important in that year. 3D printed device saves lives, 10 innovators who changed the world in 2013. There's Scott and Glenn doing a TED Talk, New Yorker magazine, but this is my favorite one. 3D printed implants, godlike doctors save a baby from deadly genetic defect, which is pretty awesome because we know that's only half true, that it's not a genetic defect. So, and then that same year, President Obama in his State of the Union address said, new workers are mastering the 3D printing that has the potential to revolutionize the way we make almost everything. And you know that if a politician says it, it must be true. So we knew we were really on the right path then. So this is case number 2, and I'll try to be kind of quick about this. It doesn't really add anything, but it's sort of interesting for those of us, particularly on the congenital side, or anybody interested in congenital and heart in general. You'll see why. So this is a 16-month-old patient who'd been in the hospital his entire month. He had TED absent pulmonary valve, and as many of us know, it causes airway malacia, severe airway malacia. In fact, some of these kids are born and can't be supported and have to go on ECMO, or frankly, many of the kids just die right at birth. So this kid was also on really high vent settings. He was paralyzed, sedated. He was on a PEEP of 20, but he continued to have respiratory arrest, requiring bag mask and CPR. The other thing that's really interesting, this is the interesting part for me anyway, or for those of us who do congenital, he had PLE, just like a Fontan gets from having high central venous pressure over time, or Fontans develop PLE. And this kid, because of his incredibly high intrathoracic pressure, had high central venous pressure in the same way that a Fontan did. And so he actually developed PLE from PEEP. And as I said, he never left the hospital. Here's his airway. We put on 2 splints in his case. Same thing, ventilator course. He's on 20 a PEEP. In the operating room, we're able to drop him down to 13. And then by 3 weeks out, he's down to maintenance PEEP. This is the other thing that's really kind of interesting. So here is his serum albumin. So with protein losing aneurysm, you spill protein and you have diarrhea and spill protein in your stool. And so you have low albumin. Green at the top is normal. The little red triangles along the bottom are when he got albumin infusions, and you can see he's getting albumin infusions all along, and still subnormal. And then by 1 month out, he's climbing up without any more infusions. And then by post-operative day number 38, he's up to the normal, and his PLE goes away. Same thing with immunoglobulin. You spill immunoglobulin into your stool, and you can see immunoglobulin levels are low, except for when he's getting along those red triangles, when he's getting immunoglobulin infusions. And you can see again by day number 28, he's got normal immunoglobulin levels. So his PLE goes away because we're able to get rid of it. So in these kids, this was life-saving. And the first 5, like I said, they were in extremis because we didn't really know if this was going to work. So we only did the very sickest kids. In fact, that was how the FDA only let us do the sickest kids. This is done under something called Expanded Access Program. We can think of it as compassionate use. But as we've gotten more experience, now the FDA is letting us use things like to prevent tracheostomy. If there's kids who are still maximal medical therapy, on a vent, paralyzed a lot of times, high PEEP, but still having acute life-threatening events, and they're headed towards a trach, the FDA is now letting us use that as an indication. So life-saving sometimes and certainly life-altering, and I'm going to show you an example of that from something that we deal with in congenital heart surgery. So again, TED absent pulmonary valve, as the case number 2 had, associated with tracheobronchomalacia, again, sometimes extremely severe. So here are 2 patients, exactly the same, 2 newborns with absent pulmonary valve, patient A and patient B. So they both had severe tracheobronchomalacia, primary bronchiomalacia, but they were both intubated, paralyzed, sedated. They were prone. They were still having current respiratory arrests. So patient number 1 was born at another hospital, underwent standard of care, which is tetralogy flow repair. We try to get the PAs, which are ginormous, from the blood sloshing back and forth their entire fetal life, and that's what crushes the airways. So what we do is we close the VSD to try to decrease the pressure on the right side. We sort of plicate the PAs, take some of the PAs out, try to make them smaller. Sometimes they do a comped to put it in front of the aorta, and they put in an RVPA conduit so that there's a valve conduit, so you no longer have that free regurgitation going back and forth. So he had that in another hospital. Patient that was born here had splint placement. So patient A continued to have severe tracheobronchomalacia, which is very common. A lot of the times when they're bad, operating them doesn't work. It really doesn't. And so patient B got extubated, went home, and came back at 6 months for his elective TED repair, just like any other TED. So patient A came to here, then got a splint, got extubated, discharged. He's already had his first conduit replacement at 9 months of age, and he'll need repeated conduit replacements throughout his life. So I think this is going to be game changing for these kids with TED absent pulmonary valve and severe tracheobronchomalacia. So life-saving, but also life-altering. Patient B should have maybe a 25-50% chance of ever needing a pulmonary valve put in there, most of which obviously is, we know there's done in the cath lab now. So totally different course now for the rest of their lives. So also life-altering, not just life-saving. So what have we done so far? So actually, we've done now 35 patients to date. All were sick. 29 had a trach or were intubated and were ventilator dependent. 15 had a history of cardiac arrest. 5 were, had a history of ECMO, or a couple were actually on ECMO on transfer and on entry to the hospital. 31 were chronically hospitalized, meaning more than a couple months. 15 had been in their entire month, including case number 2, who had never left the hospital in 16 months. I should mention that kid's home. He's now 8 years out. He's decannulated, home, normal kid. Case number 1, by the way, is now 10 years out, also home, doing great. Mean age at implantation of these 33 at the time patients was 10 months of age. Sometimes they get more than one splint, right? They can get one bronchial splint, or they can get tracheal and bilateral bronchial, sometimes even more than one on a bronchus or a trachea. So 72 total splints in those 33 patients. Again, now it's become more of a spectrum. Initially, all the kids were really, really sick. And now they are letting us do some kids that are less sick, i.e. just to avoid a tracheostomy. 27 of the 33 are long-term survivals. I would say 1 is, I would classify as probably one death is probably splint related, 2 are possibly, and the others are not related. Other things like dying of single ventricle heart problem. Everyone except the kids we've just done are home, and they've all gotten better in some way, whether it meant you were on the vent, got off the vent, you were trached, you got decannulated, you were stuck in the hospital on on a regular vent. You got to go home on a home vent. So everybody has had some form of de-escalation of care. So where are we now? We're working with the FDA on our pivotal clinical trial, which means we want to get a full PMA or full FDA approval for this splint to be used. It's been quite a journey. You know, we were designated, they had a fast track program going on for important devices that needed to be fast tracked. And so I think we're in our 10th year now of working with the FDA to try to work on getting our pivotal trial going on the fast track. But hopefully, we were hoping for Q3 or Q4 for first patient in, but now it looks like because of some additional studies that the FDA wants us to do, that it's probably going to be Q1 of the following year, but we're very excited to do it. Could also talk a lot about my experience working with the FDA, but it's been somewhat frustrating. It feels a little bit like this at times. But eventually I think we'll get there, and hopefully by Q1 of next year, we'll have first patient in. I just also want to give a shout out to Materialize. So Materialize is an additive manufacturing or 3D printing company. They're out of Belgium. So Materialize has as part of their policy that they pick essentially orphan products to support, and the splint is one that they've picked up as an orphan product. They're unlikely to make their money back ever. I think they're a little bit hopeful that maybe they will, especially as we've started to expand indications to less sick kids. But they're really doing this as an orphan product, so we really appreciate everything that they've done. They've actually opened up a plant in Ann Arbor to help get this splint off the ground. So with that, I will stop. I tried to keep it short and have some time for discussion or any questions. So thanks very much. These are some of the kids that Glenn and Scott's invention have really helped in a bunch of different splints in different sizes. So thanks very much, and I will stop sharing my screen and take any questions.
Thank you, Rick. That was a very innovative and outstanding, review of the history of this. And a couple questions I have, two questions I have. One is, how what's the prevalence of this disease? How frequently are you seeing patients, and that you're considering this, and what proportion of patients actually qualify, at least in the current state of your approach, of all the patients that you see with bronchomalacia or various forms of it? That's the first question. And then the second question, I think for certainly a lot of the younger audience, we'd love to hear more about the pathway to innovation that you've experienced with this approach and product.
So, I don't actually know what the exact number, the prevalence number would be, X out of, how many for severe tracheobronchomalacia. I can tell you, so we probably get 1 or 2, I'd say 1 to 3 inquiries about the splint a month. As it's become more and more well-known, it's probably up to something like that. So we're getting a lot of inquiries. A lot of them don't qualify on the expanded access program, which means maximal medical therapy. And again, now need for tracheostomy. Most of them don't qualify. They have milder forms of tracheobronchomalacia. The pivotal trial will allow patients that are less symptomatic, not dying, to come into the trial, but that have significant symptoms, and of course have to have the physical findings, the CT scan findings of greater than 50% stenosis, along with their clinically significant problems. I mean, you can think there are like, we got one, it's a 15-year-old girl who what she does is cheer, and she can't keep up because she has pretty significant tracheomalacia. And it may seem trite to us, well, then, it's just cheerleading, but that's lifestyle limiting to her. This is what she does. And so patients like that who aren't able to come into the current expanded access program will really benefit from this. So we're turning down a lot of patients. Again, it's probably anywhere from 1 to 3 a month between Glenn and I getting calls for them. So, but I can't really answer the specific question beyond that. As far as the pathway to innovation, I mean, for me, it was serendipitous. I mean, I think Glenn was literally walking through the ICU and ran into me and, you know, said, and I want to say this has been a great part of my career. This has been such a nice additive piece to what's really a great job already. And so I think he just ran into me. It could have been any of my partners. And he's like, hey, I got this kid, he's dying. And I got this thing I think can help him. He's like, do you think you can put it in? And I was like, sure. Yeah, I think I get it. I think we can do that. And he didn't tell me that he'd only done it in pigs and it hadn't worked. So he failed to mention that piece. But as far as my entree into the splint, it was purely serendipitous. But overall, the experience in learning how you interface with the FDA has been interesting. The FDA at times feels like they're helping, and at times exceedingly frustrating. You know, they understand. They're caught. You know, we've all seen it in the media. You're too slow. You're too slow. But then as soon as they approve something that has some unknown side effect, you know, they get vilified too. And Congress is telling them they're too slow. Congress is telling them that they're screwing up too many times. So they have a tremendous amount of pressure. So I understand that. And so they understand that this is a really important device, but they're also very cautious. They really want to push this through, but it's almost like they're stumbling over themselves because they want it, but they can't let it go through. And I'll give you an example of something that's frustrating. So you do a pre-submission. So you spend all this time, you put together this huge thing, you meet with them, they help you hone this thing down. You put everything in that they say you should change, you negotiate, you change everything, you submit it, and then someone else looks at it and everything that the other group told you to do, they're like, no, why are you doing it this way? Well, because you guys told us to do it that way. Like, no, well, that's not okay. And so there's stuff like that that's super frustrating. Like, oh, then there are things that we changed back to the way that we had it, and the FDA told us to change it. And then when we submitted it, they were like, no, you should do it this way. Like, well, that's the way we had it. We changed it because you guys said to change it. So stuff like that's frustrating. It's a slow process, you know, but overall, it's been really rewarding. It's been fun. I'd encourage, you know, that device development is a fun thing to do. It's exciting. It's fundable too, whether it's through small business or there are device specific also grants. So orphan product grants and things like that. So it's been really, really, I'd encourage anybody with any kind of interest or background. And even if you I don't have a background in biomedical engineering, but if you do and you're excited about it, you know, there's lots of opportunity here at Michigan to do this sort of stuff. Any other questions?
Questions from the group?
Hey, Dr. Ohye, this is Gardner. I'm just using Alex's computer here. I'm curious about your pathway with using a bioresorbable material for this device. Have you had to prove that degradation products are not deleterious in folks who have had this for a long period of time? And have you looked at how the device integrity has changed over time in folks who have been implanted?
Yeah, so the answer is yes to the first question. They're very interested in the degradation products and growth, so both related to what you're asking. PCL has been used for a really, really long time, but somehow we stopped. The FDA wants us to like reinvent the wheel. Like we're doing in vivo in animal models, and we're doing in vitro degradation. So in other words, you put it in a fluid and you analyze the degradation products to see if there are any things that are things like carcinogens. And again, this PCL has a track record of decades of use, but we're having to do it again, which is a little frustrating, and it's extremely costly to, as you would imagine, to put this in an animal and watch what happens. Fortunately, they're letting us do some of that concurrent with the trial. They're not going to make us have all the animal data out. We just have to have it. So we'll have the trial, right? And then at some point, we'll have data to submit for a PMA. And at that time, we'll also have to have more degradation. So thankfully, they're at least letting us do some of the animal studies, because imagine if we had to do 2 years of animal studies, which is going to set us back another 2 years. So the answer is yes, they want to know that. As far as how long it stays, has structural integrity, and what we'd estimate is something like 2 to 4 years. We have some serial studies, but the problem is it's hard to justify. The way to see this is with MRI. It's hard to justify in a kid general anesthesia if he's clinically asymptomatic. So really the only serial studies we have are kids that are symptomatic or getting a study for some other reason. Otherwise, it's just impossible to justify putting a kid under general anesthesia just to look at the splint. But those that we have, they look like you can't really see them that well, but they appear to start fragmenting probably somewhere around 3 years of age based on some of the MRIs. We have one kid who, unbeknownst to us, had a cartilage, a genetic defect that was a cartilage defect. And that was really the root of her problems. And she, like when I went in to dissect everything out, she was a redo too. She also had cardiac surgery. Her airways were so thin and friable, I got into them probably 10 times on the way in. And so she continues to have problems. And so she actually went and had an open surgery about 2 months ago, and she's 5 years out, and her splints are all fragmented at 5 years. So that's really the only data that we have other than growth data. None of the kids have had either ones that got studied or clinically significant problems with growth, which is a little bit of a tough sell to the FDA. But that's an example of something. Well, like, how do you know? Well, they're clinically asymptomatic, so we're not going to study them. We can't justify studying them. Well, how do you know there's not a problem? Well, because they're clinically asymptomatic, they don't have a problem. So anyway, but anyway, that's the answer to your question.
Thank you.
Yeah, you bet.
Other questions?
It's a quick question, Rick. This is Dan Drake. This is fascinating, and a huge congratulations to you and your team. Coming from the outside, this is really stunning work. My question for you is quite simple. What do you anticipate to be the natural history of this disease? Obviously, in the past, nobody's survived it. So you've got somebody who's at least 8 years out. What is this picture, do you think, going to look like in their 20s or 30s? It seems very optimistic. Is that the case?
Yeah, I think so. It's hard to obviously extrapolate from something that had 50 to 80% mortality. So if you look at milder forms, those forms that are treated with tracheostomy and positive pressure ventilation, where you would stent them open with air pressure for 2 years, and generally then the airway regains its integrity, and you can decannulate those kids. Those kids then will be fine for a lifetime. And not have any issues. I mean, it's important to know stuff like this doesn't help with fixed anatomic stenoses, right? It won't fix that. But they'll need that needs to be treated surgically. And sometimes kids can have more than one thing. I've had ones where I had to slide fixed stenosis and put on a splint. So some of that may dictate their long-term outcome. But the other thing, I'll mention one other use, which is kind of exciting. So there's something called tracheal agenesis that a lot of you guys will know what it is. Basically, you're born without a trachea. There have been no long-term survivors. So what people try to do is they take you have a TEF basically that attaches your trachea to your esophagus. So they try to use the esophagus. Then they substitute the esophagus, trachea, bring out a fistula, and put in a G tube. And they have tried many times and have short-term survivors using the esophagus. But you can imagine that is like the ultimate in tracheomalacia. So now what we're doing, and there are 2 long-term survivors where we've helped other centers, I believe it was Pittsburgh and Wisconsin, get splints for these kids and splint the esophagus. And so there are now 2 long-term survivors, long-term meaning, months and years for tracheogenesis. So that may be another kind of cool niche market for that.
It's terribly impressive. Really, it's just great work.
Thanks. Again, credit goes to Glenn and Scott for sure.
Attention, please. The National Weather Service has canceled the severe thunderstorm warning for the surrounding areas. Attention, please. The National Weather Service has canceled the severe thunderstorm warning for the surrounding areas. Attention, please.
My comment isn't as exciting as the warning, but Rick, I recall when I was at Dartmouth, we had the Thayer School of Engineering, and we had breakout, kind of innovation centers, and we often would have our PhD and MDs go over to their meeting, the innovating arm, to talk about clinical situations that there may be cross-fertilization of ideas about how to, study something and bring something to market. And I wonder, what your perspective is about, one, our role and responsibility to kind of having this transdisciplinary approach to innovation, and what would the role specifically be about our department creating more opportunities to bring together experts from different fields to study and innovate.
In the past, we've done that. We've had touch points where we could talk about things. As you well know, Mike is bringing over some BME students to spend time with us, and we've done that before. We've actually approached BME directly with some problems to see if there was anybody interested in working on them. So I think it's really important that we do that, because unless you walk through there and look at the posters, for instance, even just walking through some of our labs around here, we have no idea what people are doing, even in our own labs, much less over in biomedical engineering. So you have to, I wouldn't say force it, but you have to make it happen. It just doesn't happen naturally. A BME isn't going to show up at my door just by happenstance, lost, and ask for directions, and or sit on a plane next to one by chance. So I think it's incumbent upon us to make sure those interactions happen. Glenn had an idea, and so he went over there. But there's tons of things that we can think of, that we have issues with. This is a problem. How are we going to fix that? And that can help. And there used to be the CUBE grants, right, where you had to have 3 different disciplines. And that was another way to try to jumpstart some of these things. And we had applied for some of those in the past on different people over here on our side. So no, I think your point is an important one, that it is incumbent upon us to make these things happen and to participate.
Yeah, I'll add, that's a great point, Donnie. It's something that I think we have a great opportunity with how strong biomedical engineering is, and how much innovation and investment in innovation here through various donors that contribute. So you all know there's a Frankel Innovation Fund as well that has a fair amount of money. There's various sources, and so through a partnership with BME, I don't know if Gardner is still on, but we are starting an opportunity for a research fellow or during ADD time to work kind of in concert with BME for innovation, and that can be used as one of a few platforms to bridge that gap between our department and BME. And our hope is that we have more frequency of meetings, innovation meetings, where people can come with ideas and ultimately have the IP folks involved have the right type of engineering involved to move things forward. So we'd love to hear everybody's thoughts on how we can make that better once we start. But I think we'll see that movement this summer, as Gardner's can be the first person in that role.
All right, if there's no more questions, you guys know how to get in touch with me if anybody wants to chat on the side about any of this stuff. So thanks again for the opportunity to speak here, and I will see you all around the hospital.
Thanks, Rick.
Thank you, Rick, for an outstanding overview.